I'm Dr. Tammy Prince, and you are watching my show, Health Tips with the Nation's Bedside Doctor, on Clark TV Network, where we believe in the future. On this show, we have real talk on real issues that affects our communities every single day. You could have been anywhere else on a Friday night. It is Friday night, y'all, and the week is here. You could have been anywhere else, but guess what? You're right here with me, and for that, I say thank you very much. You're going to learn a lot on today's show, so I hope you stick it out with me. If this is your first time finding me, yay! Stay with me. I promise you're going to get smart on this show. If you've been here before and you follow me all the way from 108 Praise Radio, thank you. Continue to follow me. You will be rewarded, I promise. So, you know, last month was Black History Month, but for me, each and every day is Black History, obviously, because I am African American. But I said in my last show that I was going to be highlighting a different Black person that made contributions to the medical field. And so I'm going to continue with that. And today I want to highlight Dr. Alexander Augusta, who was the first Black physician appointed director of a U.S. hospital. Dr. Augusta earned his medical degree at Trinity Medical College in Toronto, Canada, and established a successful medical practice in Canada before relocating to the U.S. in 1862. Drafted to serve in the Civil War, Dr. Augusta became the first commissioned Black surgeon in the U.S. Army. He later became the first Black physician to direct a U.S. hospital, Freedman's Hospital in Washington, D.C. If you watched my show yesterday, I talked about Freedman's Hospital, and I highlighted another pioneer who was Dr. Daniel Williams, who actually was also with Freedman's Hospital. And he actually opened the very first Black-owned hospital, Provident Hospital. Now, Dr. Augusta, after leaving Freedman, continued in private practice and became a Howard University Medical Department professor in Washington, D.C. Thank you so much, Dr. Augusta, for all that you did for myself and every other physician who came behind you. I salute you. So as you can see, there are many trailblazers that open up the doors for me, and I'm going to continue to shout and scream their names because they need to be recognized. They did their best to tear down walls for me, and I'm going to continue to do my best to tear down walls for those that come behind me as well. So I call that pay it forward. You need to pay it forward. Whatever profession you do, pay it forward.
That's right.
Now, in other medical news, I was reading this morning, you know, we were talking about acupuncture, and we're going to actually talk about a little bit of that in this show. But acupuncture has been used to treat almost everything from epilepsy to schizophrenia, but now they're actually coming out with a study that was done to test it for menopause. So it looks like there was a study that was done out of the University of Copenhagen in Denmark and the University of Southern Denmark. And what it did was it tested 70 different women, and they wanted to predominantly focus on The one outcome that, as women, we hate the most with menopause, hot flashes. Who wants to be hot all the time?
Oh, that's right.
Hot and cold.
And nobody else is hot and getting cold. So you're looking at yourself like, why am I feeling this way? So they wanted to test this out. And so what they did was they tested 70 women, and the team gave half of the women one 15-minute session of standardized acupuncture a week for 5 weeks. And then the acupuncturists involved in the study had an average of about 14 years worth of experience. So they were pretty experienced in doing this. The remaining individuals were part of what they call the control group, and they received no intervention at all. Now, each of the participants then had to complete a questionnaire that assessed what their symptoms were. And after just 3 weeks, the participants in the acupuncture group noted a decrease in hot flashes. At the 6-week mark, 80% of them in the acupuncture group believed that the sessions had actually helped them. Now, the acupuncture did not only reduce hot flashes, those in the experimental group also experienced significant drops in the severity or frequency of sweating, which we all hate to do in the middle of the night, sleep disturbances, emotional symptoms, and skin and hair problems. So those are other issues that can creep up when women are going through menopause because of the drop in hormones. So the one big problem with this study that I found is that there was really no good control for this because there's not really a good placebo for acupuncture. What they use, they called it sham acupuncture, but to an untrained person, it looks the same as regular standard acupuncture. And so this is what one of the limitations with this study is. In medical field, we want randomized, double-blinded studies as gold standards to show whether or not a treatment is going to work for the general population. And so this study doesn't have it, but what it does is it just kind of highlights where we probably need to hone in on more studies and try to come up with better control groups so that we can have a blinded randomized study on this, because I do think that acupuncture does work to some extent. We just don't know the full effects of it. So I applaud the University of Copenhagen for taking this by the reins, and hopefully those of us that are over here in the U.S. and in other countries can do the same so that we can figure out how to help women through this tough time.
That'd be great.
So
Non-hormonal.
because that's what a lot of people are looking for
Holistic,
nowadays,
natural.
is something that they don't have to ingest in their bodies. We know that medicines work, but for some women, we can't use those medicines. And so this is where this type of study would help us to be able to find an alternative method for our westernized standard treatments. So there we go. When I come back, I'm going to introduce these two beautiful women that are sitting next to me as we discuss infertility.
It's harder whenever there's a bigger group. Pretty much a good day for me would be people leaving their hands off of me. I'm always called names. Everywhere that I go, there's always someone calling me names, calling me gay. I've been choked, thrown up against a wall, punched. Nobody's ever tried to help me.
Good.
I don't remember how it started.
Go to that.
Oh boy.
We just found it. Our back and forth. Victory. Fumble. Repeat. It always came back.
Dad!
Whoa!
You made time.
That was perfect. Okay, here we go, throw it!
Yeah.
You probably don't remember what you told me.
Nice.
But I heard every word.
Oh yeah, like I can think of so many kind of just
Awkward. Do I look familiar? I should. You might remember me from here. Here.
oh my gosh, like
Or maybe even here. But an awkward silence can be a great thing. It can actually be a perfect moment to reach out to a friend and ask if they're okay if they seem down. It doesn't matter how you say it.
You all right?
Everything's okay?
G?
You all right, girl? You cool?
Bug and dog.
Just show you're there for them. Go on, Kelly. Seize awkward.
that's right. Okay.
Like yesterday, for my show,
Hey,
some eating disorder.
you haven't really been yourself lately. Are you okay?
I mean, that is like one of the hard.
Find out how you can help a friend with their mental health at seizetheawkward.org. How to know if you should reach out to a friend. Your friend might be.
We are back, and like I said before, I have two beautiful guests sitting next to me. One is Dr. Samantha Fitz, and the other is Dr. Monica Best. So we're going to be discussing tonight a topic that most people don't want to talk about. It's like that dirty word that nobody wants to say, infertility. Yes. And, you know, women have been embarrassed and are still embarrassed when they can't produce children for their families. And everyone is always looking at it, well, what's her problem? Why can't she have kids? You know, but sometimes it's not her. Sometimes it may be the husband. Sometimes it's both of them. Sometimes there is no issue. We just don't know why. So we're going to actually talk about that tonight. Obviously, we're not going to be able to cover every single thing associated with infertility, but we are going to give you the basics that you need to know and also the resources that you will need if you are, in fact, having issues with infertility. Now, to my left is Dr. Samantha Fitz, and she suffered infertility and miscarriage. She has been married to Elroy, her husband, of 7 years, and they are now the proud parents of Nadia, and they live here in Atlanta. Over the past few years, Samantha has motivated other women with her message in her book. And we're going to talk about her book today because it's really very good. You need to go get it. So Samantha graduated with top honors from Alabama State University, my daddy's alma mater.
Oh, wow. Go
with,
on it. All right. I need to meet your dad.
Yes,
All
with
right.
a Bachelor of Science degree in special education. She earned her master's in special education from Georgia State University in Atlanta. She went on to earn her education specialist in education leadership from Lincoln Memorial University in Tennessee, and her doctorate of education from the Atlanta campus of Argosy University. Samantha is a member of Boulder Crest Church of Christ and Alpha Kappa Alpha Sorority Incorporated. Unfortunate, but it's okay.
It's all right. Oh,
It's okay.
yeah,
We are
it's
sisters
okay.
in the
Yes,
Panhellenic
we are.
Council.
Yes, we are.
I
Let
love
me
you the
guess.
same. I
Delta
love that's
Sigma
right.
Theta.
That's
A lot
right.
of my good friends are Deltas. Okay,
Got
but
a
it's
lot
okay.
of good, both
Yes.
Delta and AK.
Okay.
That's right.
Okay.
I love
It's
you.
okay.
I love you. I
too.
love you.
I'm a group lover.
Yes,
Okay,
that's right.
okay.
Now, she is an autism special education specialist in the central office of Atlanta Public Schools. So you probably will see her again on my autism show that's coming up in a couple months.
Great.
She is also a reading endorsement instructor in Atlanta Public Schools through the Metropolitan Regional Education Service Agency. Samantha has been in education for over 20 years.
Wow.
Welcome,
Yes.
Samantha.
Thank you for having me.
Absolutely. And then this beauty to my right is actually, she's my personal doctor, but her name is Dr. Monica Best, who completed her fellowship in reproductive endocrinology and infertility at Emory University School of Medicine. Dr. Best earned her undergraduate Bachelor of Science degree in biology from the University of Michigan, where she graduated with honors and with multiple academic awards to her credit. Dr. Best is a native of St. Louis, and she returned to Missouri for medical school, where she was awarded a full academic scholarship. Wow.
It's really good.
She's smart, y'all.
Yes,
She's smart, y'all. Now, also,
Expensive.
during medical school, Dr. Best became interested in research in reproductive medicine. She completed her residency in obstetrics and gynecology at the University of Chicago School of Medicine. And during this time, she realized her love of teaching residents and medical students. She was elected and served as the chief academic resident of her class. She went on to receive extensive training in what we call REI, or reproductive endocrinology, ovulation induction, in vitro fertilization, and the minimal invasive surgery during her fellowship at Emory. She was awarded the prestigious Fulbright Scholarship. I told y'all she is smart, where she researched and later published work on the novel Rapid Non-Genomic Actions of Sex Steroids at, you went to Italy?
I did for 9 months.
I'm sorry, the University of Pisa, y'all. If you've never been to Italy, it's such a beautiful place, and this place is no exception.
Wonderful
Absolutely.
experience.
She has published, she has authored, she has done many a research in her field, and I am just so thankful that you are here. She actually was awarded the Mom Approved Fertility Specialist by Atlanta Parent Magazine subscribers in 2016 and 2017. I am so glad to know you.
Thank you
Absolutely,
for having me.
Absolutely.
Touche.
Oh, yeah, thank you. See, I like to toot my guest horns because,
thank
look,
you.
I have to vet all of my guests, and nobody that comes on here is not knowledgeable in their areas of expertise. And so, you know, that is very, very important to me when I bring my guests on, because I need to make sure that you are learning proper information, that you're not just getting it from Google. No Dr. Google up in here.
I know that's right. Experience.
Experience.
Filtered truth.
Absolutely.
Yeah.
So I'm going to start with Dr. Besk and ask some questions, and then we'll jump into Samantha. So what actually is infertility?
You know, infertility, it's so important for patients to really understand, okay, when should I seek some help? You know, really there are two main cutoffs for infertility. If you're less than 35 and you've been attempting pregnancy for more than a year, that constitutes infertility. If you're over 35 and you've been attempting for 6 months and have not achieved a pregnancy, that constitutes infertility. Now, it's important for me as a physician to kind of dig a little bit deeper in terms of, you know, how, you know, because patients come in, they say, I've been doing predictor kits, or I've been doing, you know, checking cervical mucus and doing timed intercourse, but really what I want to know is how long have you been having unprotected intercourse? Because sometimes patients will say, look, my husband and I have been having unprotected intercourse for 5 years. We've been attempting for 1 year. So, you know, so it's important to kind of dig deeper, because 5 years is really significant infertility. So it's important to kind of seek care if you meet either one of those definitions, depending on how old you are.
Now, do those ovulation kits actually work?
They do, actually. The ovulation predictor kits do work.
And we're talking about these kits that you can get over the counter from any drugstore. And what they do is you test it at certain times in your cycle to see whether or not you're ovulating. Generally, you'll test it right after you have a period.
Usually, in most cycles, you can kind of start testing, depending on how long or short your cycle is, around day 9 and every day until your surge. Now, there is a population of women, for example, with PCOS, where the predictor kits are just generally not accurate, just because hormonally, there are derangements in their LH levels. So my patients with PCOS, I say, look, stop.
Don't do that.
Stop buying the kits. Really, oftentimes those patients are going to need some help making an egg each month. And then we help to time when intercourse occurs or when treatment occurs to get sperm to the right place at the right time.
Now, how common is infertility?
Oh my gosh, really common. And I think that's one of the main things. We want to get the word out.
You're not alone in
raise
this.
awareness because so many women suffer with it. Somewhere around 7.5 million people struggle with infertility. So that's
a little over about 10% of women. So that's pretty significant because, of course, when you're going through this, you think I'm the only one that's doing this. But no, there are about 6-7 million others that are going through the same thing, in various degrees. And when we're talking about this, we're normally talking about between the ages of 14 to 44 years of age.
Like your reproductive age women, about 10% of that population suffers, but we know that the older we get, the more likely we are to experience infertility. So, for example, if your age is 21 to 30, 1 out of 10 people is going to have an issue with infertility. If you're 38 years old or greater, it's 1 out of 4. And I think it's just important to understand just kind of, as we get older, we're more likely to have things that undermine fertility like fibroids, tubal factor, endometriosis that's gotten bad enough to affect your anatomy, or also other medical problems, worsening of medical problems that might impact ovulation or other factors that undermine us. So just
diabetes is one that comes to my mind. Huge issue, especially if it's not controlled, is a big issue for them. High blood pressure.
Oh, absolutely.
Is also another one.
Absolutely. And just, ovarian physiology. The older we get, the fewer eggs
less our
we
eggs
have.
work. Because as women, we come into this world with all the eggs that we're ever going to have and need. Unfortunately. And men are not like that. They can reproduce sperm, constantly, and we can't do that. So, of course, your eggs sit around for, 20, 30 years. They're getting old, and they may not work as proper as when you were younger. So
That's right. That's unfortunately for men, they make new sperm every 3 months. Wow. So, technically they have sort of rejuvenation of sperm, whereas our eggs have been there even since before we were born. Yeah. And over time, as we approach menopause decline, and also over time, there's some genetic injury to that pool of eggs that increases our risk of miscarriage over time.
Yeah. So now, I alluded to this earlier. People always think it's the woman's problem.
No.
But how often is it occurring in men?
Oh my gosh. So, the way I think about this simplistically is that it's the 30-30-40 rule. So it's 30%. Oftentimes we find a female factor like blocked tubes, diminished ovarian reserve, fibroids, other medical issues like PCOS, where the women aren't making a mature egg each month, 30% male, whether or not it's a sperm production issue or some kind of anatomic problem where sperm isn't able to come out into the ejaculate properly. And then 40% of couples, it's both of them. So there's some male factor, there's some female factor that is sort of combining
And making
to
it difficult.
and to make it difficult for them to get pregnant. So important to realize that couples always are really scared to come seek care because they're like, we're afraid it's going to be his fault, or we're afraid it's going to be my fault. No, actually, there's a comprehensive evaluation because we don't want to miss something on the female side, on the male side, or both.
Correct. And speaking to that point, I remember having a few couples where I had to not only treat the woman with Clomid, and we'll talk about our treatment options, I also had to treat the husband with the same thing. And once I did that, I got them pregnant even before I had to send them off to
wonderful.
the specialist.
They were thankful.
They were
you.
very thankful. I saved them a lot of money.
That's good.
I saved them a lot of time.
And heartache.
And heartache, exactly.
Yeah.
And so, I think that definitely we have to look at both partners.
Yes. Yes.
In this,
you don't want to miss
both
that.
partners are in this together.
Oh, absolutely.
You're making a baby together. You should, be tested together,
That's right.
treated together, all of that.
That's right.
So, what causes infertility in men? We talked about a little bit with women, but what are the big causes you think for men?
Yeah, so for some men, just like in women, there can be some unexplained issue where the sperm count, either the concentration of sperm or the motility of sperm is low. There also can be genetic reasons why men may not be creating enough sperm. So the sperm counts are really, really low. Generally, if they're less than 1 million total motile sperm, we're looking at their karyotype to see, okay, are their chromosomes normal? Sometimes there can be a mutation on the Y chromosome, which is what makes somebody male. And so that can be a reason for decreased sperm production. The other thing is some people are born without what's called a vas deferens, which is basically the tube that carries ejaculate from the testicle out through the penis and into the ejaculate. And so if there's not, a transport mechanism, they're making sperm, but it can't get out.
It can't get out. There's no conduit.
So there's no conduit, right. And so, oftentimes that's associated with the cystic fibrosis mutation, which can be more common in Caucasians, but we've also seen it in African Americans. So that would be something that you would
just
test.
don't think that, because I'm not a certain ethnic group that you can't have a genetic issue. With mixing of the races,
that's right.
None of us are pure.
That's right.
None of us are pure black, pure white, pure Asian, pure Hispanic. So we have to test for all the genetic components that we can just to make sure that there isn't some kind of genetic issue going on that you didn't know that you had. You could have just been a carrier and, you didn't know that you had it until something like this where now you need to get pregnant.
That's right. And absolutely. Most people that have absence of the vas deferens are carriers for cystic fibrosis. And in fact, my last 2 patients that were diagnosed with cystic fibrosis mutations, African American.
There you go.
Even
I've
though
had
it's
patients
technically more common in Caucasians.
Yep, I've had African American patients with cystic fibrosis as well, so it can happen. I know also we're talking about a huge surgence of measles, mumps because of non-vaccinations. But let me tell you something about the mumps, because the mumps can get something called orchitis. And
That's
orchitis, is an infection that affects the testicles. And if it affects the testicles, then you can become sterile.
That's absolutely
This happened to somebody that I
right.
know, so that's why another reason that vaccinations are important, because you want to prevent the adverse complications from that. It's not just, we just want to, give people shots. We are actually trying to avoid things later down the road for people.
The downstream things. The other thing I didn't mention in terms of male factor is some male children are born with undescended testes. And so if that's not corrected right away after birth and it's not identified until later, sometimes those men, just because of the increased warming of the testicle inside of the body, if it's non-descended, that can cause low sperm counts later on.
And then also along those lines, varicoceles,
Absolutely.
which are fluid that is in the testicles,
Right.
Can cause that as well.
That's exactly right. That's really common too. And sometimes, it's those are kind of difficult because those are really common both in men or men that are coupled in a couple that is either affected or non-affected by infertility. But you're probably more likely to see an increased correlation of varicoceles in couples with infertility.
Yeah, and more specifically what a varicocele is dealing with the veins. So obviously you have veins that come into the testicles and they become too large. It heats the testicles. You get fluid.
That's right.
There you have it.
Right.
Varicocele, and then there are also hydrocele, which is the actual fluid that can build up in the testicles. So all of that can come into play and affect sperm counts and things like that. So we touched on some problems that can also happen in females. We talked about ovaries not working properly. One of the big offenders is something called polycystic ovarian syndrome. Right. And so what it does is it creates a hormonal imbalance, and so you may not ovulate as you should. We also know that with PCOS, a lot of times they have other comorbid issues going on. Diabetes is a big one.
Yeah, that's absolutely a big one. And sometimes what I have to do is kind of, treat the patient to optimize health, some of those comorbid conditions before we can move on to pregnancy. Just because if there is diabetes, that needs to be very well controlled, just because poorly controlled diabetes, especially with an A1C in the teens, it carries an increased risk for birth defects. That's very, very significant. Yeah. So those patients, you want to kind of get their health problems under good control, then move into treatment from there for safe pregnancy.
Absolutely. Yeah. And for both partners, some other risk factors, alcohol use, drugs, age, old eggs, old sperm can cause issues
old
too.
Sperm above 50.
Exactly.
There's some increased risk for autism above that of the rest of the population.
Being over or underweight, so the two extremes in women can cause that. Right. And having sexually transmitted diseases can sometimes cause that, because what it does is it scars and it blocks tubes and things like that. So those are other causes as well. So now Samantha is here because she has actually had a journey through infertility and now into motherhood. And so I want her to touch on, from a patient standpoint, what it was like for her to go through this journey, thinking that she probably was alone, when now she knows there are about 7 million women that are also going through this. So why did you actually write your book? Her book is called Journey of Hope. You actually have it with you. I have it on my Kindle, so I can't show you the
So the title is Journey of Hope, Love, Marriage, and Overcoming Infertility at 40. So that's the exact title. So you asked, why did I write the book? I wrote the book so I can inspire women through my personal journey of going from being single to married, if that's what you want to do, because I wanted to be married before I, conceived. That was my personal choice. And also I wanted to inspire women that you too can go from being infertile to motherhood. So I wanted to inspire women through my book.
Absolutely. So now I was reading in the book, and like I said, you all need to go get this book. It is really good. In chapter 3, you start talking about how you had just been informed that you had a miscarriage, and what's going on in your mind as you're getting this diagnosis, and then also what happens after that diagnosis.
And so just to kind of take back, I was 36 when I got married, and I know, just like the doctor said, that I'm in that range to where a lot of complications can happen when you're over 35 to trying to get pregnant. And so at first, you know, when I went to my OBGYN, you know, you guys start having the conversations with your female doctors. Hey, what are your plans? You know, the biological clock is getting ready to start ticking. You need to go ahead and start trying to conceive. And so, and he told me if I had not conceived within the next year, then I'm going to start medication. You know, if that's what you want to do. And so, my first thought was like, medication? I don't want to be Octomom. Let me start doing things naturally to conceive. So again, I started researching natural ways to conceive. And so voila, it was the summer of that year. So that next January, naturally I did conceive again because I didn't want to have to take any medication at the time. And so I'm like, okay, I'm pregnant. But within the next week, that's when I had my miscarriage. And I was devastated because, again, miscarriage is not a topic that a lot of women talk about.
Unfortunately, we don't.
Yeah. And so I'm thinking like, what is miscarriage? And one thing about it, I didn't tell my mom until later. Well, actually, I didn't tell her I was pregnant. And then when I told her after I had the miscarriage, I called her. I was at the hospital. And I begged her, I said, Mom, please don't tell anybody. Don't tell my aunt, my cousins. I was embarrassed.
So
You feel like you were a failure?
Yes,
And
I was
and
embarrassed.
that is, there's nothing further from the truth. Just because, again, miscarriage is so common.
And I didn't know that at
Like
the time.
35 to 40% of women your age would have miscarried with at least one.
And sometimes
I didn't
people
know
don't
that.
even know that they've miscarried.
Yes,
you know?
exactly.
That's how common it is. So,
And so when I went to my doctor, he actually celebrated my miscarriage. When I said celebrated, he said, yes, there's an opening. I was like,
Things
what?
are
What?
working.
I was
Things
like, what does
are
that
working.
mean?
Yes.
And so that one statement, it helped me to kind of like reset. And okay, it's possible I can get pregnant again. But at that time, I still didn't want no one know. So I can't believe I wrote a book and put all my business in the book
you
now.
did, but it's good.
At that time,
It's
no.
It helps
Yes.
people. It helps
It's
people.
empowering because here's the thing. Even if you had miscarried, like, you know, kind of what happened, your odds of having an ongoing pregnancy because of the age that you were at the time that this happened still far outweighed your risk of having another miscarriage.
Okay.
So that's why I, too, would, you know, kind of flip things around and say, look, it happened. You got pregnant. I know things are working.
Yes. My
but
twos
I
are
know,
open.
Right. But I know
Exactly.
that
Yes.
there's a certain risk of having a miscarriage, and your odds of having an ongoing pregnancy the next time are much higher.
There you go.
So I wish I knew that at the
See?
time. So I
That's,
didn't know that.
I mean, that's
Yeah.
all part of, you know, the education. I think
Exactly.
we
And that's
need to
why it's so
share.
important
Yeah.
that you find a doctor who is going to educate you properly because there's so
Absolutely.
much out on the internet. You know, we talk to our friends and, you know,
Yeah.
they don't know.
Yeah.
The internet doesn't know, but our doctors do. You know, there's a reason that we went to school for as long as we did. We know things. So,
And believe it or not, he did not prescribe medication at the time.
Yeah.
He still waited until that 1 year. And then the few people that I did share, you know, they was like, oh, now you're extra fertile now. You know, you'll be able to get pregnant right away. And then, again, by the time I saw him again, that within the year, I still had not conceived.
wow.
Yeah.
So now, at the end of chapter 3, going into chapter 4, you started talking about your different treatments. So, what were some of the different treatments that you tried to pursue?
Okay, so by that next summer, after the miscarriage, again, that 1 year was up. And then again, with my age, it's actually 6 months, but he actually gave me a year to attempt and not conceive. So the first thing that was prescribed to me was Clomid. Again, so that was the first medication. And I guess the doctor here can talk a little bit more from the medical point of view exactly what Clomid is, but I know it's supposed to help.
Yes,
You know,
it just drives, basically just helps to drive ovulation.
Yes.
So in a normal month, you're going to make 1 mature egg per month in general. And what Clomid does is it sort of tricks the brain into creating more of the stimulant, which is FSH, to stimulate the ovaries to make more than 1 egg. So the goal really here is 2 to 3 mature eggs, not really more than that.
And hopefully one of them getting fertilized.
That's right.
In the process. Normally, when we give Clomid, we give it during days 5 through 9 of the menstrual cycle. So it's important for us to know where you are on your cycle before we start giving you that medicine, or else it's not going to be effective.
That's right.
And so after a few rounds of the Clomid, it was not working. So now you get into the point of frustration that, you know, where, you know, you time everything out. And then, you know, my husband and I did what we had to do. But now it was kind of like what you would kind of see on TV. We started being on a schedule. You know, I started looking at, you know, my app, saying, okay, this is my time. Come on, let's have sex. Yeah. So it's kind of,
it gets stressful. It takes the fun
it
out
does.
and adds
So we
stress
started
for
that
both
way.
the
But
male
my husband
and
was
the
okay
female
though
partner.
about it.
Okay, well, that's okay.
He was okay about it.
That's good.
He was okay about it. I think sometimes, of course, human nature, he did get frustrated at times, but for the most part, no.
Well, stress plays a big role
It does.
in women not being able to ovulate properly. So
you're layering on top of this problem that we know is already underlying because you're not getting pregnant like most couples would within a 6-month to 1 year period with stress.
Exactly.
So during that time, my doctor left the practice, and I said, wow, this would be a good time to transition. So let me Google, because my insurance company did not provide it did not cover fertility treatment.
And most of them don't, unfortunately. Or if they do, they cover it only to a certain point. So that's something that I would love for our medical societies to lobby these insurance companies, because this is expensive, and it's more of a problem than I think they even imagine it would be.
It should be treated like every other medical problem.
Yeah, it should.
Is the bottom line. And there's some states where they've mandated that it be covered.
Good.
For example, so in Massachusetts, Maryland, Illinois, it is mandated.
That's
coverage.
amazing.
I need to go to one of those states.
Yeah.
I know, right?
Figure out how they were able to lobby for this. So if you provide insurance in those states, you have to cover infertility.
That's amazing.
That's what we need here in Georgia.
Absolutely.
And so insurance did not fund it or did not cover it. So what I did was I researched and I looked for a OBGYN that also did fertility treatments in his office, so he can kind of build some things with my insurance, but also I would pay for treatments. And so I found a new doctor, and then he started, doing the assessments, and then he also gave me an HSG exam.
To evaluate your tubes.
We'll talk about that.
We'll
so
talk about
I
that.
had that painful test, and then and once he ruled out there was nothing, I guess blocking, so he began prescribing Clomid, and then I started taking like Menopur, and then I started doing IUI. So I started doing a lot more. You
started escalating your therapy.
Yes.
And what IUI is, basically, it's artificial insemination.
That's right. Intrauterine insemination is what that stands for.
Now, you also talked about you doing some other kinds of alternative medicine, so acupuncture and reflexology.
Yes. And so, again, fertility treatments are expensive. So, after failed procedures, I would say, okay, what's less expensive? And then I was able to conceive naturally before through reflexology and getting massages. So I stopped that procedure as far as the medication, and then I started with the natural thing. So, again, I'm a researcher by nature, and so I started seeing the correlation between acupuncture and fertility. And I found a doctor, and my husband, one thing about my husband, he was supportive of me throughout the whole process. Of course, whenever we had our assessments, we had unexplained infertility. I mean, they said, hey, his men are swimming just fine, so he wasn't an issue.
Tubes are open, uterus is fine.
So he was fine. He was being a man. He was like, okay, it's going to happen when it happens. But I'm like, oh, no, my biological clock is ticking.
That's right.
I'm going to have to, put some work in this. And so when I told him about the acupuncture I found, he was like, well, you don't like needles, But at
it's
that time,
a different kind of needle.
Yeah, it is. Well, he didn't know. All he knew was,
just needles. Yeah.
And so I did the acupuncture. I did that for a little over 6 months.
Okay.
I did it. And then, again, so I'm the type person, when I try something, I'm looking for results the next month or two.
Yeah.
So I tried the acupuncture treatments for about 6 months, and it was expensive. It was $85.
It's
a week.
expensive. It is very
expensive. And so again, count 85 times, 6 months. I'm thinking like, okay, I pay for other procedures, but not that. But at least it was in increments. And so I abandoned that. And so what would happen is I would go back and forth between natural and then, okay, let's start medicine
And
again.
medical
Yeah, because
treatment.
I was just trying to just find something that would help me.
Yeah.
Is that the best option, to go back and forth, or to stick one treatment out and then switch to something else?
I mean, oftentimes I employ kind of a combination approach. If I feel like it's something that isn't going to interfere and may help, I will let patients do acupuncture.
Yeah, I don't see a downside
massage
to acupuncture or
techniques.
reflexology. Yeah. And what those are, what they can do basically is to increase the blood flow to your organs.
And diminish stress. If you are experiencing a lowering of your stress level, I think that can only be good as a complement to even medical therapy.
Absolutely.
The one thing I do caution patients about is some of the herbs that some of the acupuncturists use, because they do have some weak hormonal properties that can sometimes interfere with kind of the medical therapy and your body's own natural, more potent hormones.
So always make sure that you check with your physician before you try any herbs or over-the-counter remedies, because you don't want to be spending money and then all of a sudden you're having something cancel out because of that. So, just make sure of that.
I would say the one reason why I was going back and forth is because it started to become costly. And so I was trying to find the most inexpensive way that will still probably work. So that was one of my drives. So had insurance probably paid for it, I probably would have stuck with IUI. It would have just, I probably would even have considered natural as I got into it.
And the way I think about this, because they've studied, acupuncture, infertility treatments, and outcomes for a long time. There's one large study that showed that people who did acupuncture actually had higher pregnancy rates with infertility treatment. But when you look at sort of this meta-analysis, which is like a bunch of studies together, and what's the impact of acupuncture on infertility treatment outcomes, there doesn't seem to be an improvement. Now, there are individual studies that show that it can improve outcomes. And so, again, there's no study that proves that it's harmful. So if you're somebody who experiences a lowering of their stress level, either by massage or acupuncture, I say knock yourself out.
Absolutely.
Exactly.
Go ahead and do it, because it's only going to help you get into the right mindset. Lowering stress, we don't know how to quantify its negative impact on treatment. So if what you're doing is lowering your stress level, whether that's full body massage or reflexology, please.
And that's exactly
massage, whatever you need to do.
Exercise.
Whatever you need to do.
To lower stress, because again, we can't quantify it. Is it helpful? Yes. I think most people would tell you lowering stress is a good thing. And is it harmful? No. I don't think we have any reason to believe it's harmful. So
let's talk about Geritol for a second, because you actually took Geritol.
Yes.
So let's try to debunk this myth or not debunk it.
Yes. So ultimately, that was the one thing. So there was a baby in my bottle. I know there's a saying, if you research, there's a baby in every bottle. So I took one bottle of Geritol, and I was able to conceive naturally.
Right. I mean, it's hard to believe that was the only thing.
I was exercising.
Like
as well.
there was, there are other things that kind of combine, I think, to optimizing health that sometimes will lead to spontaneous
Do we even know where that myth
pregnancy.
started?
I don't think we know where that myth started. I will tell you, I have patients that come in and tell me all about their Geritol. But
like, what? Geritol's for old people.
Right.
Yeah.
Again, I think we need to, step back, take a look at the infertility factor. Because, if somebody's taking Geritol and their tubes are blocked or their partner doesn't have sperm,
exactly. It's not going to,
I can guarantee you that's not going to be effective.
Exactly.
But even Geritol has a disclaimer on their website. I mean, if you go to frequently asked questions and say, we don't know where this myth got started, it, and so we do not confirm that this is, they actually had to address it on their website.
Yeah.
But there was a baby in my bottle, along with other things I did, like exercising and the massages and everything.
And so what exercising did was it helped you drop 12 pounds.
It did.
And you actually got pregnant without treatments.
Yes,
So
that's
it
correct.
does happen.
Thank God.
For some people, we know that they go through years of infertility treatment, never get pregnant. They decide, okay, I'm done with this. Let me go on and live with my life.
Yeah.
Bam, they're pregnant.
Yeah.
And so it happens.
Yeah.
Or, I mean, I have really, like, a couple of my favorite patients who have a baby from IVF, had their baby spontaneously conceived after treatment.
Yep, I know several people like that.
And adoption as well. A lot of times people seek adoption, and then they end up having their own baby.
That's
I think, you know what, it goes back to that stress level.
That's exactly right.
And stop thinking about it.
That's
Because a lot of my
exactly
colleagues would say,
right.
Samantha, you're trying too hard. I mean, I did put in a lot of work.
But, I think, like, that kind of advice,
I know.
when
you're going through it, it's not
when
helpful.
you're going through it, sometimes is not helpful.
Yeah.
Right.
And also the sit down and relax when there is a problem
Yes.
can be
Yes.
detrimental.
It's hard.
Oh,
It's
I was
hard.
told
It's
that
hard.
over and over again.
It's
Oh,
hard.
just relax. Just relax. Yeah.
It's not
It's
good
hard.
advice
Yeah.
for somebody over 35 that has a year or more of infertility.
So let's talk about some of the types of testing that you have to go through. Samantha alluded to
Yes, I
one
did.
of the most painful ones.
Yes.
Hysterosalpingogram,
Yes.
formerly known as
HSG.
HSG.
We like to call
I call it HSG.
A hysterosalpingogram is a mouthful.
Yes,
It is.
yes.
Really, it
So,
is.
HSG, what is the HSG, Dr. Bess?
Yes, so I've had the HSG done myself before.
I've had it done before.
I have, and it's painful.
And it is a very crampy test. And so basically what we're doing is we're placing a catheter. We start off with a speculum exam, kind of like a pap smear. We place a small catheter, oftentimes with a balloon that's inflated on the end of that, into the lower segment of the uterus. And then what we do is we put dye into the uterus under x-ray guidance so that we can track the flow of the dye through the tubes. We can see, are there kinks in the tubes? Does it appear as though there's scarring or blockage of the tubes? And does that dye spill into the pelvis? That would be an indicator of tubal patency, that the tubes are open and they're working the way that they should. And so, as one can imagine, forcing that dye through the uterus and through the tubes, the body's reaction to that is to cramp and spasm.
I cried.
So it can be
And I was up a wall.
I usually just recommend taking an anti-inflammatory that does help
Don't
with
get
some
scared.
of the
If you
cramping.
have to have it
please
done,
have it. It's
it
worth
done.
it. Think about what's on the other end
Totally
if you
worth
get
it,
it fixed.
especially since pregnancy rates are increased within 3 to 6 months after having it done. So there is some therapeutic benefit too,
absolutely.
aside from the diagnostic.
I mean, but once it's
benefit.
over, it's over.
That's right.
It's
It's
painful.
really
When
quick,
it's over, as long as you don't
And then
take-
you're good after that.
It's a quick test.
Now, the other thing that is also done is a sonohystogram.
That's right.
Which it sounds the same as HSG, but not.
Yeah.
Because now we're evaluating more of the uterus.
That's right. That's right. So the HSG is really great for evaluating the tubes, but it's not so great with evaluating the uterine cavity. And so oftentimes as reproductive endocrinologists, we'll do both because the HSG is really the gold standard for evaluating the tubes. The SHG, or the saline sonohystogram, is the best way to evaluate the uterus. So we're looking for things like fibroids, polyps, which are just sort of abnormal growths of tissue that can push into the cavity where implantation occurs and lower the rate of implantation. And so with the saline, it starts off very much like the HSG, except for we're putting salt water under ultrasound guidance inside of the uterine cavity and scanning through to make sure that we don't have anything inside of the cavity, scarring, polyps, fibroids that might negatively impact us.
And for me, I also had that procedure done, and what was frustrating that all the tests came back good. Like,
Yeah.
okay, so
And a lot of times they will.
You were 10% of people who have unexplained, which is super frustrating.
Very.
You almost want there to be something
so you can
So that
fix
you
it.
can treat it. Exactly.
But honestly, there's probably some issue with tubal transport that we can't really assess well with the HSG. pregnancy or things getting to the right place at the right time efficiently and unexplained.
And sometimes we also have to do something called a laparoscopy, where we put a camera inside and we have to look inside to see what's going on with the organs. A lot of times that can also clue us in if there's an issue with scarring.
That's right.
The tooth may be scarred down so much and you can't see it on the HSG. You may have issues with endometriosis.
That's right.
And we can see that on the laparoscopy. So some women end up having to go through that as well. Now, there are so many different treatment options. The most common is going to be the artificial insemination, but we do other things, assisted reproductive technology, where we basically take the egg and we take the sperm and we put them together in a Peachtree dish.
That's right. That's right. And then we grow them in the lab for 5 days, or anywhere between 2 to 5 days. We can do an embryo transfer. But I have a daughter who's the result of that technology. And
so it works.
So I'm amazed by it every day when I see my little nugget walking around.
Absolutely.
So the other benefit of that is it allows us to preserve fertility. So we can freeze embryos for our later use that will always be the same age that we were at a younger time when we froze those eggs or froze those embryos. And so it does kind of, it is a gift that sort of may keep giving to you as you age and your eggs age within. You can always go back to those younger embryos or younger eggs and have a more optimal pregnancy rate later on.
Let's quickly discuss the differences between surrogates and gestational carriers. I know a lot of the celebrities are now coming out saying that they've either used a surrogate or a gestational carrier. So, let's talk about that briefly.
Yeah.
So, gestational carrier is somebody who basically is housing or providing the womb for the embryo. The person does not have any genetic
link to that embryo.
It's from the mother and the father. And a lot of women use that because they may have medical problems that prevents them from actually carrying a baby. It could be life-threatening for them to do so.
Oh, wow. Either life-threatening medical problems, or I've had patients in the past that have had endometrial cancer and have had to have a hysterectomy or really severe endometriosis, like you just discussed, where they had to have the uterus and the ovaries and tubes removed for one reason or another. So they would then utilize a surrogate to achieve a pregnancy.
Now, egg donors. We need to discuss that because, there are different types of egg donors, and we generally will reserve egg donors for what reason?
Well, really, patients may use egg donors for really a couple different reasons. One is, we just discussed, somebody that's needed a complete hysterectomy for one reason or another, some medical problem like endometriosis or, significant bleeding after a delivery. Sometimes that may lead to a hysterectomy and the couple's not done building their family. Also, severe diminished ovarian reserve or advanced age. Those patients may want or to better utilize their resources, select an egg donor that has a much higher rate of pregnancy and lower risk of miscarriage to achieve a pregnancy. And so, oftentimes in those cases, we select an egg donor who looks like the intended parent or the female partner and has similar physical characteristics, ethnic background, things of that nature. And then we use the partner sperm to fertilize those eggs to create embryos that we then will place in the mom's uterus. And so in most cases, unless there's some significant uterine factor, the female partner can carry that pregnancy. So even if it doesn't have a genetic link to her, it has a genetic link to the male partner, and she's able to carry that pregnancy, deliver, breastfeed.
And she has all the rights and privileges of had she used her own eggs.
That's exactly right, because who would know? And unless
and even
you
if they did
decided to say anything, you know, and so we talk about those things with patients before they elect to make that decision. But ultimately, the egg donor's given up her rights to those eggs long before that egg retrieval happens, and legally, the person who carries the pregnancy, delivers the pregnancy, is the mother. That's it. It's all said and done.
Now, tell me this, why are infertility treatments so expensive? You know, Samantha alluded to her having to go back and forth between treatments because she just could not afford it.
Right.
Why are they so expensive?
I mean, it's really the reason why probably 50% of people who need treatment don't actually get the treatment that they need. You know, and you can imagine, you know, for people in sort of the lower socioeconomic strata, that is it's even more difficult to them. And so there's probably a higher percentage of those people that just don't get the treatment that they need and they deserve, quite frankly.
And also it's 50-50. So let's say that I had to pay for IVF out of my pocket. I know the price range I've seen from $18,000 to $100,000. All depends, I guess, everything that goes into it. Let's say, you know, I could take out a loan. I mean, that's a lot of money to invest in for a procedure that might not work.
It is. And so that's kind of one of the things I wanted to make sure we address today because, again, I love the title of your book, Journey of Hope. I think people need to be given that hope that this is not an unattainable dream, right? You know, there are financing options, and I'll be the first one to tell you I financed my daughter.
Okay.
I have financed the storage of my embryos because I do want to achieve another pregnancy. So, you know, I have used some of those financing options you discussed. There are also, I know in our clinic at SGF, we have a program that allows people to not only use donor eggs, donor embryos, their own eggs as part of IVF, and we have a guarantee option, or what we call a shared risk option, which allows you basically to pay for your fertility services, but with a guarantee from us that if you don't achieve a pregnancy, you get your money back.
Oh, that's amazing.
So,
see, I wasn't aware of that option.
Yeah.
Well, I didn't get that
That
far.
option.
And that may not have been available to you at that time.
It may not have been available to you.
That's good.
At that time, but you know, usually people that are paying $100,000, just to kind of put things into perspective, are people who are using surrogates, who are using also egg donors. So those people can plan to spend that much money just because
that's just the range that you see once you're researching.
Right. I mean, their infertility treatment is a little bit more complicated and involves payment of somebody to carry, and you know, but for the average patient with infertility, you know, you're probably looking at somewhere around maybe $15,000 between IVF plus medications. Again, in our shared risk program, you may pay a little bit more than that, but again, you've got the guarantee
that you may get it back.
That
That's
if
really
you
good.
don't achieve a pregnancy within like 6 fresh cycles, frozen cycles are included in that, then we will give you your money back. And that allows
really
people to pivot to other treatments
Yes.
if for some reason out of 6 cycles you're not successful, to pivot to things like egg donation or embryo donation if you choose to do that. So, you know, there's so much hope in all this.
That is.
There's scholarships, there are other things of that nature to really help people afford it. But ultimately, I'd love to see this be mandated
through insurance
coverage. And again, there are
We have
states
to lobby.
that do
we have
this.
to lobby for it. As physicians,
Absolutely.
we know how important it is to have insurance coverage. We know that people don't get the treatments that they need because they maybe don't have insurance or they don't have enough of the insurance.
That's right.
You know, not with infertility, but with other illnesses, people can die if they're not getting help.
That's right.
And so, you know, once again, we were put on this earth to procreate.
That's right.
And so we need to have the ability to be able to do that without stressing where am I going to get this money from in order to do it?
Yeah.
And maybe the stigma will go down as well.
Well,
I mean,
and
because you have more and more people that
that's
are
right,
participating.
that are accessing care. And, you know, I mean, just, I know that in, you know, for example, in the gay community, there isn't that same stigma because they know, look, they need it. But there shouldn't be a stigma for us. You know, that we should be able to access the care that we need. More people are going to school and doing other things before they settle down and start their family.
That was me.
So they're going to be shifted to that later age and more likely to experience challenges.
Absolutely.
You know, so we need to have something in place for us.
Well, this has been a great conversation.
Yes.
I hope that we have debunked some of the myths that are involved with infertility, and I hope that we've been able to touch everybody. But if we just touch one person, I am forever thankful.
That's right. That's
Please don't think that you are in this alone. You are not. There are resources. Dr. Bess, how can they reach you?
So I have just recently joined SGF Fertility here in Atlanta. And so I'm actually currently seeing patients in their Meridian Mark Sandy Springs location as well as their Piedmont location. I'll also be returning to Marietta, Georgia, also to see patients there. Again, it's SGF Fertility, one of the largest fertility centers in the nation.
Yeah, and they have other locations all over in Virginia,
Maryland,
you name
South
it.
Georgia,
so just check them out, sgf.com, right?
Yes.
And Samantha, how can they reach you?
Okay.
And get this wonderful book.
So I do have a website. It's www.samanthafitz.com. My book is also available on Amazon and Barnes & Nobles. And all social media is the number 1 Samantha Fitz. Again, that's 1 Samantha Fitz.
Well, I just want to thank you all so much for taking time out of your busy Friday evening to
Yes.
come
Thank you for having
and
us.
talk with me and talk with the viewers. I think that we've educated them. And, you know, this conversation is going to continue. You may see them again on my show because I think it's that important where we talk about topics that are unsung. So that's what we're going to do.
Yes.
So until we meet again, have a great week. I thank you for tuning in to Health Tips with the Nation's Bedside Doctor on Clark TV Network, where we believe in the future. Take care. Okay, so he'll cut it off.
Okay.
When he comes back in.
Great. That was great.
Thank you.
That was fun. Yeah.
Wonderful.
Yes, you make my nut. You make